It's 8 o'clock. Good morning, everybody. Dove speaking from Sunnybrook. Just like to welcome everybody to Journal Club. Our 4 core sites are all engaged, although I don't see that Gary has arrived at Baycrest, and welcome to everybody joining from outside the core sites as well. On this day of climate action and protest, we have 2 very exciting presentations on hopefully enlightening, maintaining our ability to protest long into the future. So with that, Dr. Dmitry Petrov will start with the short presentation. And I remind everybody to mute their microphones during the presentation. So with that, Dmitry, over to you.
Thank you. Good morning, everyone. For those of you who don't know me, I'm a new PGY4 fellow in geriatric medicine, and today I'll be talking about associations of amyloid, tau, and neurodegeneration biomarker profiles with rates of memory decline among individuals without dementia. So I do not have any conflicts of interest to disclose. So National Institute on Aging and Alzheimer's Association recently published a research framework which was focusing on defining Alzheimer's dementia based on pathological process rather than clinical consequences of disease. And the authors envisioned that defining Alzheimer's disease as a biological construct will enable a more accurate characterization and understanding of the sequences of the events that lead to cognitive impairment, and hopefully will lead to a better understanding of Alzheimer's dementia as a whole. So they thus proposed the biomarker classification being classifying the pathological process, and they focused on the classification involving amyloid deposition, tau deposition, and neurodegeneration. This biomarker classification, the clinical significance of this classification is not yet well understood. And so the paper that we'll be talking about today, recently published in the Journal of the American Medical Association, aimed to shed some light on this issue. The study objective was to study the association between biomarker profiles and memory decline in population-based cohort of individuals without Alzheimer's disease, ages 60 and above. So the participants of the study were people age 60 and above with no dementia. They enrolled a total of 480 participants into their study and followed them for a mean of 4.8 years. The intervention that they were interested in is evaluation for the ATN biomarkers, and they were using the amyloid PET, tau PET, and brain MRI imaging to accomplish this. As this was a prospective cohort study, they did not have any controls. What they did is they did clinical evaluation of the same population and compared it to the biomarkers, which we'll go into more detail in the future slides. The outcome that they were interested in, what they wanted to study, was the numeric memory composite score. So they're more interested in seeing rate of memory decline. And the setting of the study was population in Olmsted County, Minnesota. So they recruited the participants by first enumerating the population using medical records linkage system of the Rochester Epidemiology Project. Then they randomly selected participants by using a 10-year age and sex strata to ensure that there is an equal amount of male and female participants in the study. They essentially included anyone who was age 60 or greater, did not have any medical contraindication to imaging studies, and did not have a diagnosis of dementia. And the way that they evaluated the participants was by a consensus committee, which was comprised of physicians, neuropsychologists, as well as the study coordinators. And the outcome measure that they were interested in was the numeric composite memory score. The way that they came up with the score is they used 3 validated memory tests, namely the Wechsler memory scale revised logical memory, the Wechsler memory scale revised visual reproduction, and the auditory verbal learning test. They obtained the Z score by using the mean and standard deviation of cognitively unimpaired individuals ages 50 or greater for each of these tests. And then they obtained a domain Z score, which was the mean of the Z scores from the 3 tests that they used. And this domain Z score then was itself Z scored against a weighted mean and weighted standard deviation, and the weights were the age and the sex of the population that they were studying, so that their goal was that this approximately 68% of the population would have Z scores in the range of -1 to +1 by the end of all of the analysis that they've done. And so the way that they conducted the study was they had an index visit, including a clinical evaluation incorporating cognitive testing, amyloid PET, tau PET, and brain MRI, and they had at least 1 follow-up visit at 15-month interval. And really, they're trying to compare 2 models. The first was the clinical model, which they looked at the age at index dates, sex, education, CMC scored index, and APOE status. And the CMC score is the cardiovascular and metabolic conditions score. Really, it was a mean of 7 conditions that the US Department of Health looked at as a marker of vascular health. So the 7 conditions incorporated in that score were diabetes, stroke, coronary artery disease, congestive heart failure, any cardiac arrhythmias, hypertension, and hyperlipidemia. And then the second model they used was the clinical model with the addition of the biomarker groups. And as there are 3 things in the biomarker groups: the amyloid, the tau, and the neurodegeneration. There were 8 possible groups that could come out of the different combinations, ranging from having negative amyloid, negative tau, negative neurodegeneration to having all 3 of them present. And they accounted for learning effect as well. This was seen in previous studies where non-cognitively impaired adults actually had some improvement in their performance on memory testing with repeated tests. And they knew that this effect existed and by how much this can increase the Z scores. And so they incorporated this as an offset in their model to make sure that there's no confounding happening from the learning effect. They also made sure that they only included participants who had non-missing data, so they did not have to account for any missing data in their study. And then what they did is they compared the 2 models using the likelihood ratio test. This was followed by cluster analysis to investigate which of the ATN groups showed more rapid memory decline. And so this table shows the characteristics of the study participants. as you can see, majority of the participants were in the triple negative group, so they did not have any amyloid, pathological tau, or neurodegeneration. 92% of participants were cognitively unimpaired, and the last group, the 8 plus T plus T N plus group, had the most highest amount of participants who had mild cognitive impairment, which is 30%. And if you look at the ApoE4 carriers, it's interesting to know that majority of the carriers were actually in the amyloid positive 4 groups, around 40% versus 21% in the other groups. Another thing to note as well is that 473 of the 480 participants self-identified as white. Otherwise, based on the other characteristics, there is no significant difference in age, education level, ApoE carrier status among the different groups. There is, however, a higher proportion of males compared to females in all of the groups. And this is the continuation of that table that shows that there is also no significant change in the rate of Z-score decline among all of the different groups. And the total amount of memory Z-score evaluations on average was 4 to 5, but there were a few that participants that only had 2 evaluations done. And what the study also wanted to do in order, as there wasn't as much follow-up for some of these patients, they included the previous 2 visits before the index visit with their Z-scores to try to have a better accuracy of performance on the Z-scores in between the individuals. And these are just examples of what the biomarker imaging studies look like. The first one shows that there is no amyloid, no tau deposition, and no degeneration. And then you can see what the abnormal pathologic findings would look like in the last column, where it's all 3 were positive. And so this figure shows a plot of individual memory Z-score trajectories by age and the biomarkers. And as you can see, there was a lot of interpersonal variation of the Z-scores. For example, if you look at these lines, this represents one participant who had a few visits with evaluations of the Z-scores, and there was a great amount of variability in how that participant performed at each visit. I focus mainly on just the triple negative and the triple positive groups, showing that in general, there were very few participants in the A negative, T negative, and negative groups that were age 80 and above. And the reverse is true for the triple positive group, where a majority of the participants were older than 70 years. So what the study found is that in the clinical model, age and ApoE status were significantly associated with faster rates of memory decline, which was statistically significant. A 10-year increase in age was associated with a 0.4 lower memory Z-score at index date. Men, interestingly, had lower memory Z-scores than women by 0.5. And a 4-year difference in education associated with a 0.6 higher memory Z-score, and the carrier ApoE positive carrier status had a 0.3 lower memory Z-score. and all of these results were statistically significant. When they compared the ATN model to the clinical model, they showed that addition of the ATN biomarkers offered significant improvement in predicting memory decline as compared to just the clinical model, which was statistically significant, but unfortunately the improvement was not very large. It was fairly modest. The association with memory decline was not significantly different by age or sex. And the three groups that they showed the fastest rates of memory decline were the A positive, T positive, N positive, A, T, N negative, and the A positive, T negative, N positive groups, which is interesting because it signifies the importance of amyloidosis and the process, the pathological process of Alzheimer's disease. But they showed that just having amyloidosis alone is not enough. You need to have either tauopathy present or neurodegeneration or both in order to have significant rate of memory decline. And the other thing that they found in the study as well is it was easy to predict which group would not have any memory decline, and those were the patients who were APOE4 non-carriers and who were triple negatives. And this figure goes over in more detail on the things that we've just reviewed. So if you can see in the clinical model, the APOE4 carriers, adding that to the model had a better prediction of memory decline, as did increasing age. And then as you go down, the three groups that we spoke about showed better prediction in memory decline across all ages. So the author's conclusions were that the biomarkers provided modest by statistically significant benefit in predicting memory decline. The three groups with fastest rates of memory decline all had abnormal amyloid, as we spoke about, and the APOE4 non-carriers who were triple negatives had minimal decline, which could be useful in clinical practice. So the strengths of the study was that it was a prospective cohort study of modest size, and they really did a very good job in terms of cohort recruitment, where it was randomized and accounted for age and sex to make sure that they tried to make sure there was an equal amount of males and females in the study. They had validated scores that they used in measurement of their outcome measures, and the measurement were objective, and they did a robust statistical analysis to try to account for possible confounding factors. They also showed that there was consistency in their ATN classification. So 88 of the participants actually had their imaging done for the second time, and they compared to make sure that there's no variation in the imaging obtained, and they showed that they were consistent in both times that the imaging studies were done. And the study also performed a post-hoc sensitivity analysis, which showed that their results remained constant despite some of the other models they tried in the post-hoc analysis. In terms of the study limitations, as we saw, there was a high test-retest variation in the z-scores, and I think this has to do with probably one of the major drawbacks of the study is the fact that it was over a fairly short follow-up of 1 to 3 years. Alzheimer's disease or dementia in general can progress over many years to sometimes decades, and I think if they were to follow these patients for a longer period of time, they would have more accurate outcomes. More accurate measurements. The applicability of these findings can be challenging to the general population because more than 90% of participants in their studies self-identified as white. The study only looked at memory performance alone, and as we know that cognitive decline has multiple components to it, and perhaps if they looked at other composite measures of cognitive decline, those may have been more sensitive in picking up cognitive impairment than just memory performance alone. The study has not yet been replicated, and there still is unclear clinical significance of the ATN biomarker model. And these are my reference. Thank you for listening. If anyone has any questions or comments, I welcome.
Thank you very much, Dimitri, for a very nice presentation, clarifying something that's sometimes very difficult to untangle.
Good morning.
For our long presentation. Yeah.
Yes, so I'll try to rush through some of the slides just so we can make it on time. My name is Ramon. I'm one of the PGY5s in Geriatrics, for those who don't know me. Today we'll discuss a new article that's been published this year in the American Geriatric Society Journal on CPAP adherence and how it may slow down the one-year cognitive decline in older patients with MCI and sleep in the setting of sleep apnea. So I have no conflicts of interest to disclose. And I apologize, I'm not sure why my first few slides kind of move on without me controlling it. I wasn't able to kind of fix that problem. But today we'll be talking about some of the studies around the topic. We'll review the study of interest, and we'll do a critical appraisal and end with some discussion points. So in terms of background information on the topic, we know that age-related changes in sleep architecture is a well-known phenomena, but it's unclear whether these changes are related to an actual neurodegenerative process or just two processes happening simultaneously. It's also shown that a decrease in REM sleep percentage is associated with poor cognition and the increased risk of dementia, which sometimes happens in the elderly, but at the same time, obstructive sleep apnea itself can happen in both REM and non-REM sleep, so it's not necessarily sort of hand-in-hand in relationship to that decrease in REM sleep cycle with age. And so, and so we'll dig into that a bit deeper in some of the studies that I'll discuss. In terms of obstructive sleep apnea, we also know that it's associated with an increased risk of MCI and dementia based on some observational data and cross-sectional studies. There hasn't been really strong randomized controlled trials to explore that in detail. And so this increase in prevalence of obstructive sleep apnea in those with MCI and dementia is also an association that's seen in these studies. The risk that may be associated, this possibly could be related to, could correlate with severity, but again, some studies indicate this and others don't, and we'll see that in some studies that I'll discuss in terms of assessing the severity of sleep apnea in the setting of the apnea-hypopnea index, and they usually use a moderate stage to show that association, which is classified at the level of 15. Also nocturnal oxygen desaturation. Some studies suggest that obstructive sleep apnea may accelerate the amyloid deposition, which has been suggested as a limitation in the study that I'll discuss because they didn't look at some of this more objective data and whether or not there is an association or not. And it's also unclear if whether even if there is an association or we prove that, there hasn't been significant studies showing whether or not treating OSA with the standard methods, such as using a CPAP, could actually delay developing MCI or dementia. So the first study that I want to discuss is a meta-analysis that was published in 2017. It's the Association of Sleep Disordered Breathing with Cognitive Function and the Risk of Cognitive Impairment. It looked at 14 studies, 14 prospective studies and cross-sectional studies in total. They looked at least studies with at least 200 patients in each study. 6 of them were prospective, covering up to 4 million patients altogether. And it indicated that sleep disordered breathing was associated with 26% more likely to develop cognitive impairment. The confidence interval in that section of studies was between 1.05 and 1.5. And overall, the studies were fairly good in the sense of that there was no publication bias, but they did have significant heterogeneity between the studies. And they also grouped the MCI and the dementia group as a single entity. So it's not clear whether or not there is a distinction there. The 8 cross-sectional studies that they looked at showed that there is worse executive function, but the confidence interval was much lower. So it was a negative 0.09 to 0, so barely positive. But it failed to show that there is any global cognitive impairment association. And these studies had better results in the sense of there was not significant heterogeneity compared to the prospective studies that they looked at. We know that sleep disordered breathing from those studies was also assessed based on the clinical diagnosis of the apnea-hypopnea index, which similar to what they used in the study that I'll discuss. And the cognitive impairment was also assessed using standardized tests, similar to what we use in our clinics. Most of the data from this meta-analysis was from the United States, but it also included some studies from other areas of the world, including Germany, Taiwan, France, and Norway. So breaking it down in terms of the prospective studies that they looked at, if you look on the right side of the diagram here, so they looked at the Newcastle-Ottawa scores, which indicated a higher quality observation studies overall, scores 8 and 9, so fairly high. It's a scale that they use out of 9, so most of them were fairly good studies. Most cutoffs in these studies were an apnea-hypopnea index of 15, like I mentioned earlier, but some used clinical diagnosis, and they used measurements such as modified MMSE, global cognition, attention testings, and so they tried to adjust confounding variables, but like I mentioned earlier, there was significant heterogeneity in this subset of studies. And this summarizes some of the results that they showed. Basically 3 positive trials, and the overall pooled data showed a clinical significance in terms of that association. There was not enough data to determine if the severity of OSA played a factor here in terms of the sleep disordered breathing, and whether or not that had a change in the significance of the outcome. In terms of the cross-sectional studies, so again, if you look at the Newcastle-Ottawa scores, that was slightly lower than the other studies. So it's not as good in terms of quality, but there was less heterogeneity overall between the studies. And looking at some of the results from these studies, as mentioned earlier, the three areas that they looked at was global cognition, which did not show any statistical significance, executive function, which was barely positive, and finally delayed memory. And so we kind of have to look at further studies to kind of show that this is a consistent, it's consistent with the same results. The other study that I want to mention quickly before jumping into our study is the sleep disordered breathing and how it advances cognitive decline in the elderly. It's again an article that was published in 2015 in the Neurology Journal. They screened over just under 2,500 patients from the Alzheimer's Disease Neuroimaging Initiative with the various exclusion criteria. So they had 3 different subsets. First subset, and each subset is based on an exclusion criteria that they kind of took patients off that study. So the first subset, which was the most lenient, they looked at just over 750 patients in the MCI group and just over 1,500 in the Alzheimer's disease group. Subset 2 looked at 622 and 1,300 in the Alzheimer's disease group. And then finally, subset 3, after the final exclusion criteria, they looked at a total of 445 patients in the MCI group and just over 1,100 in the AD group. So the sleep disordered breathing in this trial, the patients had a younger age of MCI onset in all 3 subsets, and it was about a 10 to 11-year difference with a younger age diagnosis if the patient had sleep disordered breathing present. The p-value for that was less than 0.01, so fairly significant. However, when it came to sleep disordered breathing patients being younger in the AD dementia onset, it was only significant in the most conservative group, so subset 3, and the difference was about 5 years. So 83 years of age compared to 88, with a p-value again of 0.05, so significant. When you combine the MCI and AD dementia, which some studies, as mentioned earlier, do in their analysis, the sleep disordered breathing patients actually had a younger age of onset across all subsets. And then looking at CPAP now in terms of whether or not treatment, there wasn't a lot of patients that they could look at because the data was missing, as Dr. Alba has mentioned with the Dimitri's study as well. That is a limitation, but they did look at CPAP for subset 1, 2, and 3, and only 1 and 2 showed a delay in MCI onset by, again, about 10 years with a significant p-value for either subset, and age of onset was 82 compared to 72 in subset 1 and 2. In subset 3, they failed to show that trend, but they also attributed this to having a small sample size. So data only on 10 patients in the CPAP group versus 18 untreated patients. So overall conclusion from this study shows that the presence of sleep disorder breathing was associated with an earlier age of cognitive decline, and CPAP use in patients with sleep disordered breathing may delay progression of cognitive impairment, but we need further studies. And it's not clear whether or not the compliance or severity was in this subset of patients. So it's therefore we need more studies to determine this association. So I'll skip the next slide. It just basically shows the 3 different subsets and what criteria they used for the cutoffs between each subset to narrow down the population. So jumping into the study that I'll discuss today, looking at CPAP adherence and how it may slow down the 1-year cognitive decline in older patients with MCI and sleep apnea. The objective of the study was to determine if the of CPAP, whether or not the treatment with CPAP adherence predicts cognitive function decline in patients with MCI at 1 year. They also, because it's a pilot study, it was also trying to determine the effect size in the setting the stage for further trials, larger trials, and seeing which sort of factors to look at more in detail. So it was a quasi-experimental pilot study. I had to kind of familiarize myself with this type of study. And so it's an empirical interventional study that aims to estimate the causal impact of an intervention on a target population. And that's without random assignment. So instead, it uses certain cutoff criteria for eligibility. It was single-blinded, so the examiners were blinded to which group each patient fell at, and they looked at, basically at the outcomes at baseline, 6 months, and 12 months. It was a non-intentional to treat, and they had a few patients that kind of were excluded because for some reason they wanted patients that were sort of adherent to whatever arm they're going to be assigned to, and so they actually had almost a 6 months washout period before they actually made their final inclusion numbers. And so it was a non-intentional to treat. They compared memory, psychomotor, cognitive processing speed, everyday cognition, Alzheimer's disease cooperative study, clinical global impression of change scale, and the clinical dementia rating. They only had 29 patients overall after all the exclusions in the CPAP group, and only 25 patients in the non-adherent group. And they define adherence here by about 4 hours per night consistently over 1 year. They also had a third arm, which they didn't really go into detail why they had this. My understanding is maybe a baseline of MCI patients without obstructive sleep apnea. They just kind of mentioned it in the body of the article, and that was about 15 patients, and they didn't really discuss those any further. In terms of the CDR and the global impression of change scale, that was also mentioned as an outcome, but they did not include it in their main article. They had it sort of as a separate table in the supplementary data that I'll go into separately in a separate slide there. So in terms of the population, they looked at community sleep clinics, geriatrics clinics, and primary care clinics, and they looked at patients between the age of 55 to 89 with an apnea-hypopnea index of 10. So that was interesting. They didn't use the cutoff of 15 that like other studies would use. Their reason for that is they had a split night study for diagnosing some of the patients with sleep apnea, and they based the results based on an article published in 2010 in the Clinical Sleep Medicine, showing that this method of diagnosis actually underestimates the true apnea-hypopnea index, and so they used that as their cutoff. For MCI, they assessed patients based on different criteria. So they used the Peterson criteria, looking at memory complaint verified by an informant, a CDR score of 0 to 0.5, absence of dementia, and they use the MMSE as a cutoff, which we don't typically use in terms of an actual diagnosis of dementia. So to rule out dementia, they use an MMSE score of less than 24. So all patients have to have an MMSE score of 24 or higher. Memory impairment, that's 1 to 1.5 standard deviation below normal, adjusted for age and education on the Logic Memory 2 test. And finally, another criteria that they used for MCI diagnosis was an approximate 1 to 1.5 standard deviation below the normal, adjusted for age and education, and no more than one cognitive domain in addition to memory deficits. In terms of enrollment, it was between 2012 and 2014. They looked at screening just over 3,500 patients, but only ended up with 29 patients in the CPAP users and 25 in the obstructive sleep apnea group that's untreated, after excluding about 14 patients that kind of dropped out from the study at the beginning when they assessed them at 6 months. So these are the final numbers at the 6 months mark. They had to exclude patients that had unstable medical conditions and had to have 4 weeks of a washout period of any psychoactive meds, because obviously this could sort of change some of the results. And they excluded mainly a lot of patients with depression based on the Beth Depression Inventory 2 scale that they used. They also wanted a sleep partner, and that's because a lot of the questionnaires that they use and the results will include the partner in sort of assessing the patient. And they had to have absent intellectual disability with six or more grades of education. So looking more in detail about the study population, there's a few things that I want to highlight, and I have them circled here. So some of the differences were that were significant were age, sex, race. So typically younger and more males and whites in the CPAP user group compared to the non-adherent group. They also had more married status and spouse being the study partner in the CPAP adherent group. And whether or not that played a factor in adherence, but also in analyzing some of the results that I'll discuss. The apnea-hypopnea index was much higher, and that's, I think, the most compounder that I didn't wrap my head around in the CPAP group compared to the non-CPAP users, which may indicate a more severe obstructive sleep apnea. So the groups were not identical, and what's interesting is that they adjusted for a lot of these things, but they did not adjust for the difference in apnea-hypopnea index between the two groups when they did their sensitivity analysis. So some of the exclusion criteria they looked at was anybody with the diagnosis of dementia, because their focus was MCI patients. Anyone with an MRI contraindication, anyone with a psychiatric disorder that's uncontrolled, like a major depression, substance use, any unstable medical condition, and they did not go into detail about what that really means. And if they're already using CPAP or oxygen, or are involved in other studies that has neuropsychological testing already at hand, because that might also affect some of the results on our own testing in that study. So briefly talking about this diagram, again, the most important thing that I want to highlight is how they started off with over 3,500, only ended up with 68 patients, and 14 of those were excluded because they did not complete the 6 months trial for various reasons that they gave there. And just for the sake of time, I'll just move on to outcomes. So in terms of the outcomes that they looked at, because it was an experimental study, sort of setting the stage for larger trials to come, they had so many different outcomes that they looked at. Almost like seeing what's gonna sort of pop up as positive to indicate sort of what can be, like, the focus of this should be sort of emphasized on future studies. So in terms of primary outcome, the cognitive function that they looked at the memory Hopkins verbal learning test that's revised, total recall. They also looked at cognitive processing speed using the digit symbol. I'll go a little bit in detail about what these tests sort of show, as we don't typically use these in clinic. So for in terms of the digit symbol score, so they look at, for example, a set of 9 digits with a matching symbol between each digit, and they show the patient this list. And under each digit, they have to kind of remember and write down what corresponding symbol falls as fast as possible, and they usually give them an allocated time. They didn't specify what the details of the test that they use in terms of parameters, but typically it's 90 seconds or 120 seconds. And they see, so the higher number, the better the score in terms of correlation. And they try to get as much correct symbols matching with the numbers based on what they remember. In terms of other cognitive functions that they use, so they use the global cognition assessing the MMSE, and they use the PVT, which is a sustained attention reaction time test that looks at the speed with which subjects respond to a visual stimulus. So for example, a light would go on and they would have to press a button to indicate that they sort of recognize that there's the stimulus that they agreed on. And so the main measurement is not necessarily to assess the reaction time, but to see how many times the button was not pressed when the light was on when it should have. In terms of secondary outcomes, they looked at daily function and progression. And for that portion of outcomes, they had to involve the caregiver or the spouse in that case. In terms of function, they measured the study partner rated everyday cognition, so ECOG, and the obstructive sleep apnea specific function outcome sleep questionnaires. 2 questionnaires that are done. The ECOG, the higher total score on the ECOG reflects a greater impairment versus the functional outcome sleep questionnaire, which looked at the impact of excessive sleepiness on function outcome and how it affects relevant daily behavior and sleep-related quality of life. They had a score of 5 to 20, and in that case, the higher the score indicated actually a better functional status. And then finally, the CDR and the ADCS CGIC scale, these were part of the secondary outcomes, but they kind of only talked about them in the supplementary data that I'll describe in one of the slides later on. So the overall results, it's a busy slide, and there's a lot of numbers, but I'll try to summarize it quickly here in terms of what was significant. So they looked at baseline as well as 6 months and 1 year for each cognitive function that I discussed earlier in terms of outcome for both primary and secondary. Except for the CDR and the CGIC scale, which they didn't really mention why they were not discussed, but in the supplement data, they did say that it's probably because it was missing a lot of data from the study partner not completing some of the questions that they needed to assess their patients, as well as so missing data pretty much. But the significant increase was in the psychomotor cognitive processing digit symbol that I discussed earlier at 6 months and at 1 year. So that's one of the primary outcomes in the CPAP adherent group. And that was significant across the board. And I'll show later on that it was also significant when they adjusted for some of the variables that were different between both groups. There was also a decrease in the global cognition in the CPAP non-adherent group at 1 year. So an MMSE drop of negative 1.61, which was considered significant, even though small. Oddly enough, there was an improvement in the sustained attention of the non-adherent group at 6 months and 1 year, which they did not really explain a reason for. And then there was significant improvement in the daytime sleepiness in both CPAP adherent and the untreated group at 6 months. But when it came to 1 year, only the adherent group showed that significant improvement. Same thing with the ECOG. So at the CPAP non-adherent group was significant at 6 months, the reported study partner shows a significant worsening of CPAP in the untreated group at 6 months and 1 year, and the significance was only at 1 year, but not at 6 months for the adherent group. And finally, the functional outcome of sleep questionnaire also showed a significant improvement in the CPAP adherent group at 6 months, but both groups were equal when it came to the 1 year assessment. And I'll try to summarize some of these, the importance of these results in a later study, because I know there was a lot of stuff that they kind of looked at. Table 3 here summarizes similar sort of results based on the cognitive testing that they used, but they used they compared non-adjusted or the unadjusted and the adjusted group, and they saw which one had a sort of a change in this significance. And again, they only adjusted for age, race, and marital status, not for sex variation between the groups, and not for the apnea-hypopnea severity index between both groups, which were significant. And so the 3 stars that I want to mention are the ones that were significantly important. So the cognitive processing speed, DS showed statistically significant improvement in the unadjusted and adjusted results. So it was pretty consistent, and that's the main result that they looked at. Cognitive MMSE was significantly better in the unadjusted results at 1 year, but they failed to show a significance of the adjusted results with CPAP adherence, and the same thing with ECOG. I apologize, I'm not sure how much I have in terms of timing. So just a few minutes, so I'll try to focus on the important points here. So this table here looks at the supplemental data that I mentioned, and even though they had a trend toward improvement with CPAP adherence with an odds ratio that's 2 and 5 respectively there, it did not meet statistical significance because they were missing so much data, so the numbers they couldn't really be supported by in terms of the number. And this slide here summarizes the results. Mainly that I want to focus on is the digit symbol, which was statistically significant across the board for both unadjusted and adjusted group. They also looked at the unadjusted cognition using MMSE at 1 year, and the unadjusted ECOG, which were reported by the study partner, were both significant, but they failed to show significance when it came to adjusting for some of the variables that were different. And finally, the effect size was important here to kind of set the future for further trials. So for DS, it was a large effect size, and that basically means that there's a strong correlation, but only a small to moderate effect size when it came to other cognitive function testing for MCI and obstructive sleep apnea. And so the association was not as strong. Overall, we do need a larger adequately powered trial to confirm these findings. So in terms of the strength of the trial, they had no prior prospective studies looking at the effect of CPAP adherence specifically in treating OSA in MCI. It was a diverse settings of recruitment pilot study. They had blinding of the assessors, and the overall attrition rate at 6 months, they said it was low because it was only 14 patients, but I think in my opinion, 20% dropout is fairly significant. So that is sort of a soft point that they made in their analysis. And finally adjusted for some demographic differences, but again, not for some others. And so I would have wanted to see an adjustment based on all these different variations between the two groups. So not all variables were adjusted for, like I just mentioned. It was non-intention to treat, dropping the 14 patients from the initial numbers that they had. Also, there may be an association. It could be considered sort of to measure more on an objective parameter, like an amyloid burden change, and whether or not that plays a factor with treating obstructive sleep apnea. And then finally, some of the cognitive testing that they used may or may not be sensitive enough or specific enough. So you definitely need further studies to show replicability and sort of consistency with some of these results. And so for the sake of time, I just want to quickly summarize that overall, I thought that this study was an overall fair in terms of the Newcastle scale that they used for other observational studies that I discussed earlier. So a score of 7 out of 9 overall. but there is definitely some room to have had it better sort of set up in the beginning. So overall conclusion, controlling for most baseline differences, the 1-year CPAP adherence in patients with MCI may significantly improve some aspects of cognition compared to CPAP non-adherence, but we need further studies to show that these results are consistent across the board and for different severity levels of obstructive sleep apnea. And I'll just open it up for any last comments before we end our day today.
Thank you very much, Ramon, for, despite the time constraints, for getting across a detailed understanding